All right, welcome everybody to today's new meeting hosted by the Division of Antiretroviral Staff. I'm Tammy Phillips for those who don't know me. And very excited to introduce Keene, who's going to chat to us today. Claire is a health systems researcher at the Health Systems Collaborative under the Center for Global Health Research and Deputy Director for the MSc in Health Service Improvement and Evaluation at the University of Oxford. She's also a South African clinician and used to work for NSF, so many of you might know her through that space, and had a big hand in a very large field hospital in Khayelitsha during COVID times, which we won't talk about any further. And Claire's research explores people's engagement with HIV care, predominantly in South Africa, and particularly engagement over time and intersecting issues of mobility and engagement. Services. So Claire and I have been also collaborating a little bit around issues of mobility and engagement in HIV services, and Claire's worked very closely with the PhD team and is going to present work from the PhD. Thank you. Want to be on the video? I'm here. The people that I know this.
Afternoon now, everyone. So yeah, the work I'm going to show you today, I worked on PhD data, so it would be a good idea to kind of bring it back and show you what I found with your data and the data that is being produced here. Kind of expand a little bit on who I am and where I belong. So I used to work for MSF here and then went across to the UK to do my PhD under the Health Systems Collaborative, and then just kind of stayed on. But they're a really cool group. They've got a big grant on health workforce issues with people at VITS. They also do a lot on newborn care, but sort of a range of things around like wearables and what data from wearables can be used for to determine a health systems question. So across a number of different countries in Africa, Southeast Asia, and the UK. And we've got this brand new Masters in Health Service Improvement and Evaluation, which is really about understanding it through diagnosing the problem, then designing interventions, implementing them, and evaluating them. So it's quite niche and quite narrow, but sort of really trying to give people practical skills to go and do quality improvement more thoughtfully and more sort of theory informed. And the two big projects that I'm doing, collaborating with people in Cape Town. The first is called Sustain 2, and that's with Catherine Orwell. That's with Desmond Tutu and Harvard and Boston University. And essentially what we're doing there is people who've had a gap in care or had a high viral load. We're saying, well, the system as it is currently structured is probably not working for them. So let's try something quite radical on the other end of the spectrum from what we normally do, which is to get them to come to clinic more often, give them lots of counseling, give them lots of support. And let's get out of their way, give them 6 months of treatment in a club model and see if that's safe and effective. And sort of if we change what we're expecting of them, it might work for some people. It probably won't work for everyone, but sort of figuring out who it might work for. So that's one project that's NIH funded, so it's been in a bit of purgatory for a little while, but it looks like it's back online. And the other is on the move with Tammy as a co-PI, and that's looking at inter-facility mobility and transfers between facilities across the Western Cape. And does that, so first of all, is that a problem? Does it affect engagement with care? And then we'll also do a big realist piece looking at how and why and under what circumstances, what is going on when people move between facilities and why did that have any impact on engagement. The idea is to put that all together in a big co-design workshop to co-design a response, whether that's an intervention or service redesign or taking something away from the system. That'll come out of the work, mostly working with City on that one, but we've dragged in the MHS as well now. And the other bit of that we're adding is sort of a wraparound capacity strengthening research ecosystem piece, where we want to use the project to sort of cascade out some skills. So we're doing some interesting things on mapping mobility, on the realist, which is quite a niche skill. So we'll do some training around it. We'll have a knowledge exchange to kind of give people a platform and give early career researchers a platform. The one thing that at Oxford we do have is networks. So we're working with the Global Health Network, which has a mailing list of 1 million people, so they can really kind of spread what we're doing. And then we'll also be interrogating the actual collaboration. So having these regular meetings where we discuss the collaboration between Oxford, University of Washington, UCT, and sort of City and MHS, and thinking through like decolonizing that collaboration and making it more equitable. Like who should be making these decisions? If there's disagreements, who should be solving those? Like how are we structuring this collaboration at a time where everything's being renegotiated as funding is changing and falling apart, and the world is kind of in a bit of flux. So how can we do it a little bit better so that it isn't just global north telling the global south what to do because the global north has the money? So that's a big piece of that work that Sammy and I are doing, and we brought Jonathan into as well. So I don't think I need to tell anybody about the background to HIV. I think everybody here knows about it, but just to sort of frame where I'm coming from is that HIV services have evolved over the last couple of decades. So we started in the 80s and 90s with this devastation where the response was all about palliative care and stopping people from getting HIV in the first place. And then with the discovery of effective art, it changed. And it became about scaling treatment and getting as many people on treatment as possible against this backdrop of rising incidence and burgeoning population of people living with HIV. And over time, like universal test and treat guidance changed that again, and the 1990 targets changed that again, so that it was more focused on keeping people on treatment for a lifetime, and shifting the response kind of to differentiated models of care and how we're delivering care. And now that we've got new tools like injectables and AI, but also on a backdrop of severely diminished funding, we're kind of entering this new era where we realize that people are cycling in and out of care. It's not just this linear one-way direction. And a lot of the thinking is around realigning our services with what people need and want. So if it's all about engagement with care, because people are not engaged, then individually they get sick and they get advanced HIV, and at population level they become unsuppressed and they pass on the virus, then the question is what is engagement with care? So the first thing I did in my PhD was try and define this, because I realized that everybody talks about engagement and everybody means something different. So I went through a process of doing a scoping review to look at how you measure engagement. And out of that and the engagement with the stakeholders kind of came this framework. And basically what we were saying was engagement's a behavior. It's not a thing that a patient is. So if someone isn't a good patient or a bad patient, it is just at this point in their time, they are behaving, they're engaging or they're not engaging. But that engagement has dimensions to it. So there's engagement with the services, and that's kind of what we see as retention. Are they coming to clinic? Are they coming to their appointments? But there's also engagement with the treatment itself, and that doesn't happen in our facilities. That happens in between our contact and the patient. But if they're retained and they're getting their treatment and they're caring and they're taking their treatment, they'll have treatment success. And that is what gives the individual benefits. They're healthy. The public health benefit, they're not passing it on, and the societal benefit of a sort of healthy working age population. But if we want that to be sustained, we need to think about active self-management of that person being able to take all of these things that affect engagement, the contextual factors, the individual factors, the sort of family and work and all of these other things, and be able to compensate and cope when things change in their life to maintain their retention and maintain their adherence so they can sustain their treatment success. And we came up with a cool setting name of the in-care framework to kind of frame how we were talking about engagement when we then went and looked at how you measure it. So another thing about engagement, to just sort of as a background to the work, is that we know that 1990 has driven the testing and the scale of access and the sort of focus on treatment success. And that we now kind of know that it's not that linear. People are falling out of care and coming back into care all the time. But Jonathan's work showed that of the people that are starting treatment, now 2/3 of those people are actually restarting treatment rather than starting for the first time. So we know recycling is an issue. We know it's happening, but the question is, well, what are the patterns of that cycling? How are people cycling? And not just after initiation, but also after restart. And are those people different? Is it a different thing? So that's what I spent most of my PhD looking at. I used PhDC data, which every time I've presented this in Oxford or at international sort of forums, everybody cannot believe that PhDC exists. It's this magical thing that people like, wow, what a valuable resource to have individual level patient data across a whole sort of district or area and to be able to follow people between different facilities. And even some of the papers that I'm currently going to peer review keep saying, yeah, but what about when people transfer to facilities? And to realize it's really, really clear to say that this data is amazing. You can follow people and it gives you a different perspective on the engagement because it's not facility level. So I looked at this cohort of 68,000 people, adults. So the median age was 31, about a quarter were under the age of 25, 2/3 female, as we expect. They'd all initiated art in the era of universal patient treats. There were no conditions to them starting art. And they all had at least 1 year of follow-up time. So our median time of follow-up was 4 years, but I had 26,000 people who'd followed up for at least 5 years, which again is quite a privilege to be able to work on data like that. And I looked mostly at cognition and Go-Collective as sort of fairly similar areas where people are facing similar challenges to their engagement. And it was about half with a small group who had access care and both. And in that scoping review that I mentioned, we found 110 different ways to measure engagement. And within that, there are different thresholds for, what engaged is, whether it's you've been out of care for 7 days, like 50 days, 90 days, 28 days. There is very, very little consistency in the way that people measure this. But we categorize it according to that framework of measures of retention, measures of adherence, measures of active self-management, and then measures of the outcome, whether that's viral suppression or quality of life or mortality, to kind of try and categorize things and make sense of them. But the ones that we have access to from a health service perspective is really the retention measures, and then the primary adherence. So medication possession ratio, how much drug do you have on hand? Because it's not telling you if you took the treatment, but it's telling you something in between retention and visit attendance and adherence, sort of a bit of a bridge between the two. And then we obviously had some of the outcomes. So I looked at a number of different measures of retention, and treatment interruptions ended up being the most robust and most granular of them. So essentially what that is you have a visit, you get, say, 2 months refill, and you're supposed to come back and you get another 2 months refill, and then you're supposed to come back, but you come back late. If that gap was more than 90 days, we considered it a treatment interruption. And the reason we pick 90 days is because it's too short. You don't really know if the person actually interrupted treatment. They might have leftover medication, they might have to borrow, but 90 days is the point at which the national guidelines say you should change your management. So if they come back after 90 days, they need your CD4 counting. Something changes, and we're also pretty sure that after 90 days, there's probably at least some interruption in the treatment. So we looked at time to the first treatment interruption, and most people only had one treatment interruption, the median was 1. But after 6 years, nearly 3/4 of people had interrupted treatment at least once. And that's a substantial interruption of 90 days. If you look at shorter ones, 7 days, pretty much universal, like 95% of people had an interruption. Most of those interruptions happened in the first year, which we know first year is a high risk period. But follow people up for long enough, and they're probably going to interrupt it eventually. If we look at the subsequent interruptions, so the red is the first interruption, and then those people who had an interruption, the yellow is time to the second interruption, and then the green is the third, etc. There's not much difference actually. The time to a second interruption or a third interruption, fourth interruption, is a little bit quicker, and actually the hazard, a little bit more, and it happens a little bit earlier, but it's still the same basic pattern. It's not this drastic difference between people who had an interrupting again versus not. And if we look at the time for people to come back, the median time to return was about 8 months. But again, by 6 years, 3/4 of people had come back. And there is a confidence interval around that. It's blue. You just can't see it because but lots and lots of numbers were very, very narrow. But those who hadn't returned, either just hadn't returned yet, or they died and we didn't know about it for whatever reason, or they moved out of the Western Cape and re-engaged somewhere else. But work that Tammy's done suggests that people, even if they've re-engaged in the Eastern Cape, they probably had a gap in care, and most people haven't re-engaged elsewhere. So we can probably assume that they are out of care somewhere. And if we look at their outcomes, so we know that the pattern of falling out of care again is quite similar between people who, after initiation, after restart. But there is something different about their adherence because their viral load suppression is a lot lower. So a year after returning to care, about 2/3 of people are still in care. And 50% of people who had a gap in return to care have a suppressed viral load after a year. If you only look at the people who had a viral load done, that's 88%. But lots of people are either out of care or missing a viral load. And if you look at people, it's not a perfect comparison, but if you look at people who didn't drop out of care a year after they initiated, most people have suppressed viral load. So there is a difference in their adherence, and is that because whatever factors them out of care are still unresolved when they come back, and it's now affecting their adherence because it's a spectrum, and they're just different dimensions of engagement, and what affects retention. Sometimes different from what affects adherence, but sometimes it can all be sort of in the same WhatsApp group. But also sometimes what tips people back into care is not the resolution of the factors that tip them out of care. So someone might drop out of care because of a combination of things like they lost their job and family commitments, etc., etc. But what brings them back to care is something completely different, like getting sick or like a family member or a friend dragging them, kicking and screaming back. And so they're not necessarily the two sides of the same coin. They might be very different factors. So what we know from this is that it's poor retention that's really driving the gaps in 95, 95, 95, because the people that are in care are doing okay. It's the people that are dropping out of care that mean that the viral suppression in the last 95 is lower, because either they're out of care and not suppressed, or even when they're back in care, they're not doing as well. And so the question is, well, what should we do with our health system? And how do we encourage people to engage with care long term? And the answer is usually target high risk people. If we look at who's high risk, well, the usual suspect, it's if you're under the age of 25, if you're a male, you've got a slightly higher hazard ratio of dropping out of care. If you had a pivotal event, so that was getting TB, getting pregnant, getting COVID, or being hospitalized, you were more likely to fall out of care. And time in the pandemic was also a risk. Some things are protective, like having a comorbidity. So if you had diabetes, hypertension, and a mental health diagnosis, actually, interestingly, either when you started or you developed it while you were in care, that was protective from falling out of care. And whether that's because you're already engaging with the system or there's more points of connection with the system. I mean, age was adjusted for, so not necessarily because people with comorbidity tend to be older, but there's something protective about having a comorbidity in terms of aftercare, which is also interesting considering how a lot of time those services are not integrated and actually increasing your burden. Starting later, having advanced HIV when you started was protective, and starting on dolutegravir was protective. But an interesting one was having a pivotal event, so TB, pregnancy, COVID, or hospitalization when you started your treatment. Because for the first 6 months, that was actually protective, and people were less likely to fall out of it. But after about 6 months, it switched, and it was actually a risk factor for falling out of care. So there's something about those services, the antenatal care and the postnatal care, the PV clinics, that's keeping people in care, or something about the people that have those conditions. And I will admit I haven't looked at them separately, and that's something to do next. But so there's something going on that people are not going to fall out of care while they're under those services, but long term, having started art while you were on TB treatment or starting art while you were pregnant, you're more likely to fall out of care later on. And if we look at the people who had a gap and didn't have a gap, Jonathan's work shows us even more nicely. There's some subtle differences. People who have had a gap, slightly younger, but median age of 30 versus 33. So is that really helpful? They're sort of more likely to have a pivotal event, but less likely to have non-communicable diseases like hypertension, diabetes, mental health. And then less likely to be on dolutegravir at start, but mostly they're the same. They're mostly middle-aged women who started on an RTI. And so focusing on those high risk, which actually have quite small hazard ratios, 1.2 risk, is really efficient in using our resources, but it's missing the bulk of the people who need support, which are middle-aged women. And that kind of fits with Rose's prevention paradox, where most of the cases come from low-risk individuals. And the example that helped me get my head around it is older women are more likely to have Down syndrome babies. But most Down syndrome babies are born to young women because they're having more babies, so there are more of them. And so if we focus on the high-risk people, it's a really efficient use of resources. But if we want to really shift the needle at a population level, we're going to have to figure out ways to address the whole population. And a lot of these things are out of our control, poverty and big things like that, that there's not much that we can actually do, but perhaps some things that we can do are reducing the barrier to accessing care. So having after hours is helpful for men, but it's also helpful for middle-aged women. Having shorter waiting times is helpful for youth, but it's also helpful to everybody else. And sort of removing those barriers for the whole population might help us shift that needle, especially in an epidemic like we have in South Africa and most of sort of Southern and Eastern Africa, where in North America, Europe, it's the sex workers, people who get drugs, men have sex with men. Those key populations drive the epidemics. But if we have a generalized epidemic where it's the rest of the population, so our responses have to address the problems of everyone to get anywhere. So if we can't stratify people according to demographics, are there other ways to do it? And one way to look at it is, if you've got one model to describe the whole population, which is what the urban maps was, that's traditional public health, where you've got a little bit of data on a lot of people, but nobody's actually average. So what would be ideal was that each individual had their own model and their own trajectory, and we could target services at each person's needs. So that's precision medicine, where you've got lots of data on each individual. But even with 68 million, that's not really feasible. So what you can do is sort of start to find something in between, where you take people who have similar trajectories or similar behaviors and complementary groups. And that's precision public health, where you're starting to find subgroups of people based on things, it could be based on demographics, but it could be based on other things from the data. But for that, we need lots of data on lots of people, which the PhDs can give you in some respects. Because then you can start to understand the dynamics at a different level, start to predict risk groups, and you can start to target your interventions to groups of people rather than to individuals. So what I did to try and apply this was use a technique called group-based trajectory modeling, where you basically create a retention trajectory for each individual. And then the group-based trajectory modeling kind of works out the optimum number of groups where people are really similar to the people in the same group as them, but as different as possible to people in the other groups. And this is what I found. There's 5 different ways that people engage. So this is people with 5 years of follow-up time, so 26,000 people over 5 years of time. And these are the average trajectories for each of the groups. So within this trajectory, there'll be variations. Within this one, there might be variations. That's the average, and no one's average, but it's an average for a smaller group. And to be fair, there aren't that many different ways that this could be cut. But what is interesting is the distribution across them. So about 40% of people were in the yellow group. They were optimally engaged. They didn't drop out of care over 5 years, which is a decent chunk of people who are doing very well, either because of our services or in spite of them. But 60% of people dropped out, and it's not binary. It's not you're in care, you're out of care. There are lots of different ways to disengage. You can either drop out and come back, and you can drop out and come back at different times. You can rumble along a little bit in the green and then drop out. We can be in the red and drop out quite quickly and just never come back. And there was a huge portion of people in the red group who elected treatment once or twice and didn't come back. And again, they probably either yet to return, or they died, or they've engaged somewhere else. But these groups matter because the viral suppression at 5 years was different between the different groups. Still not fantastic, but to be fair, because people were starting in about 2016, 2017, 5 years of follow-up by the database closure, their 5-year viral loads were smack in the middle of COVID. So if you look at just the people who had a viral load done, still, like, people in the yellow group, if they have a viral load done, they're pretty much all virally suppressed compared to even the people who had a viral load done in the other groups weren't doing it well. And another interesting point was that the people in the yellow group, it did actually have interruptions. They were just fewer and shorter and happened later on. So they had a median of 4 interruptions of 7 to 90 days over their time, but they were still virally suppressed. Kind of begs the question of what gap matters. Does it matter if someone's out of care for a month? Especially, if people have access and they can make a plan and they can be on, that doesn't mean that they've actually interrupted treatment, but also they do interrupt for a little bit and come back and they do okay. Do we need to be as holding on to people as tightly as we do for fear of them, for fear of losing them? Or can we kind of let them go a little bit? And I don't know the answer, but it's an interesting question. Maybe explore. So the other thing I wanted to show you is that, so this is the engagement over 5 years after initiation. And if you look over 1 year, like, you can kind of get a bit more granular with the different patterns in the first year. Obviously, more people are in care, so 60% of people stay in care in that first year, and 40% drop out. But again, they're dropping out with different patterns. But if you compare that to after restart, patterns are quite similar. Again, slightly more people in care after initiation. So 58.5% versus 52.8%, and this one is 38% versus 50% stay in care. So people are dropping out more after restart. Their hazard of dropping out is slightly higher, but it's not a completely different pattern or a completely different kettle of fish. They're almost very, very similar in what's happening. And again, similar to the survival analysis, there wasn't really a difference between the people in the different groups. So the age was maybe slightly lower in group 75, that disengagement with delayed return. But again, median age of 28 versus 33 in the subgroup 1. There optimally engaged. So there's differences, but they're small. Slightly fewer females in the delayed disengagement group, slightly more chronic diseases in the optimal engagement group. Some more people had a CD4 count at start in the optimal engagement group, but again, not massive differences, so subtle differences. The implications of this, retention is the bottleneck, and it seems to be driven by these frequent interruptions, which are nearly universal given enough follow-up time. And so maybe are a normal part of a lifetime journey with HIV. Most do return to care. They've got similar patterns after initiation and restart, but worse outcomes if they've got a history of non-retention. And I think something that I've found really interesting is that engagement isn't binary. There are lots of ways to disengage, and it's very, very difficult to predict who's going to be in what group. They're all quite similar, at least with the data that we have. It's probably something that is a lot more nuanced about their personalities and their life circumstances and things that we don't collect. Another is that this, like a whole population approach, might be something that we need to think about in this phase of the epidemic. But some interventions are never going to be amenable to a whole population approach, like behavioral interventions or economic incentives, things like that. And maybe for those, a precision public health approach might be helpful. Sort of targeting subgroups of people who behave similarly as a proxy for whatever is going on in their lives. And when I first started this, I thought this would be a really cool way to target care for people, but I don't think you can actually. But what might be useful is, say you have a clinic and you look at the distribution of your clinic population across those different groups, and you realize that your clinic has a lot of the yellow group, so you should be offering lots and lots of differentiated service delivery models. Or your particular group has a lot of people who drop out and come back quite quickly, so your clinic needs to be offering options that are different from another clinic that has already patients and something is going horribly wrong there. And so maybe it's more of a meso level support rather than a micro clinician level help to make decisions. And lastly, just that what happens in a patient's day-to-day life, for us, few of them, especially with routine data, is shadow of what's really going on. And so making decisions with that in mind, knowing that there's a lot more that's going on the ground that we can't see, but also perhaps we can fill that gap somewhat. And that's maybe linking data, which is what PPC does, which is really helpful, but also figuring out which data would be very valuable to collect in addition, considering all the constraints of time and resources. But maybe some of these new sexy methods of analysis can also plug some gaps. So that is a whistle stop of some of the things that I found over the last couple of years. And I guess a question for you would be, where do we go from here? What questions need to be answered now? And what is the priority of things to consider? Otherwise, if you've got any questions on the work, ask those as well.
Okay, so let's switch to see if there's questions online, but in the meantime, are there questions from anybody in the room?
Hi, thanks so much, Keene. This is really fantastic. I was just, this is more kind of a general question. I was just wondering, I mean, I think, yes, the complexity of sort of your lived reality, and do you know, there probably are data that would look at sort of asking the patient about their likelihood of disengaging in care, and whether that in any way measures the actual event happening as well. So, yeah.
So on that from 2 points, and I'm sure people have thoughts on this too, but from what I've seen, there's nothing that predicts falling out of care. Even fancy AI machine learning models, I think, predict 70% of missed appointments. And the biggest predictor is previous retention behavior. So missing previous appointments is far more predictive of missing future appointments than anything else. The other thing that I thought was quite interesting is that some guys in Zambia did a qualitative piece where they interviewed people about their treatment journeys. They created very similar trajectory groups based on qualitative experiences. But what was interesting was that people had very different experiences within that group. So people would come to the same pattern of engagement from very different reasons and very different things happening. And some people would remain engaged despite having the same factors that the people who dropped out of care had. It's just they were able to cope. And whether that's a personality thing, whether it's a support system thing, there was something that allowed them to ride the wave, which is why when we were discussing the in-care framework, there was some sort of back and forth about whether active self-management should be part of engagement. And I think it ended up in it because of that, is that Jonathan's analogy is the one that stuck with me. It's like, if you put people in jail, they will be retained, force them to take their pills, and they'll be adherent. But if you take that external pressure away, there needs to be some sort of self-management of the process for it to be sustained. So I'm not sure if that actually answers, or if anyone else has thoughts. But when we were working, when I was in the Sept, we had we trialed this welcome service, which for better or worse seems to have made it into the mindset of services, and it worked mostly. I don't think it worked as well as it could have, and I think I wasn't experienced enough at the time to design a very nuanced evaluation. And so I think if we had a better evaluation, we could have figured out what worked and what to keep and what to chuck. It was very resource intensive for a small amount of improvement. But one of the things we had was this checklist when a person came back to care, and the counsellor would go through all the things that could tip them out of care, all the things that took them back into care, and try and build the counselling around those factors. And that qualitatively seemed to be helpful. But on the population level, I'm good. Sure.
The PhD data also include the people who end up going to the clubs. I was just wondering how would engagement look for those people? Because I know that there's that certain pressure on them wanting to stay in the club. So before we even actually hide the fact that they're pregnant, so that the club doesn't know that they're pregnant, because then they have to take you back to the area where we clinic. So I'm just wondering what's engagement like for and maybe you haven't done to that particular group of people, but what would engagement look like for those people? Is it one of those things that, again, is it a jail? I want to stay here to make sure that I do this properly, or is it one of those things where you have that behavioral thing, like they have a little bit more freedom of, I go to my club and pick up my medication twice a year, and that's it. Like, how does it actually look, people who are part of that group?
Yeah.
Unlike the people who are actually forced to come to clinic because when you haven't been taking medication properly, so therefore they just have to contrast you when it's big. Like, how does I just wonder.
So it's everyone, but I didn't look at the difference between club patients and non-club patients. And the PhDC work could look at that, but answering from a different perspective, when I was at MSF, we did a 6-month adherence club trial. And something was really interesting from the qualitative work there was how people saw so we were giving people 6 months of treatment in the club. And there was a definite agreement across everyone, whether it was clinicians or people in the 6-month arm or people in the control arm who didn't get the 6 months, that you have to earn your 6 months. You shouldn't just be given it. You have to prove yourself first. And then there was definitely an element of we adhered because we didn't want to lose this really flexible, really helpful model. which is something when we're doing it now in Sustain, where we're giving it to people who've had a gap in care. Cities basically said to us, okay, you can't do it in the facilities, we're doing it at Lily Village because we can't be giving people something that is an advantage when they haven't done it next to patients who are doing the right thing, and why are they not getting it? So they kind of kicked us out the facility. Go do it over there where we can't.
Yeah.
But it would be interesting to look at whether club membership is something that determines which. But sorry, thinking out loud, it's a tough one to unpack because people who are engaged prove themselves they're allowed into a club in the first place. So it's like a self-selecting group. And then the club allows them to engage better. And so it's like a sort of
But then,
virtuous circle.
is that where you actually find most of those people where they disengage for like 7 days? What is that where we find most of them, or is it? They also have the 90-day period of disengagement. I think that would be interesting to think about. Like how do they disengage?
And the patterns of
Yeah.
engagement. Yeah.
Looking at I know you tend to unpack your different pivotal group of people as well. We're looking at and when the pregnancy is a different thing to be in hospitalization, and that would be my bias to do a lot of pregnancy stuff, but would be a really interesting group to look at as well.
And differing impact in club patients with rehabilitation as well.
First, just to say that I love the idea behind the concept of sustain. I think it's amazing. I mean, it's just flipped the whole mind, perspective on its, upside down. And, yeah, I think we need to be given more.
People have very polarized opinions about that one.
I think it's great. I think we have to be putting more trust in our patients. And one of those things about putting trust or empowerment into our patients is this whole frontier, its next buzzword is that kind of giving patients access to their own data. And I was just wondering with your experiences in Kailija and the study, knowing the multitude of behavioral reasons behind attending clinics or adherence. If you think just that empowerment, because a lot of them are real factors, not having money for transport or, getting a job and not being able to disclose and take time off. Or do you feel that, that next frontier of empowerment, do you think that it will be able to affect some of those barriers?
I think it will affect some of them for some people.
Yeah.
And I think my worry about Sustain is that it's gonna work really, really well for some people and not work for other people because it doesn't address their challenge. And our original study was actually, we were going to offer people a choice between, sort of a guided choice, but do you have a retention problem or an adherence problem? If you have a retention problem about coming to the clinic, let's give you 6 months of treatment and you go and sort yourself out. If you have an adherence problem, let's give you injectables. And then you have to come to the clinic more often, but you don't have to worry about taking it in between. But politics and injectables and things, we couldn't get access to injectables. So we thought we'll start with this arm. But that would be where we would want to work towards. It's like whatever the problems are, they ultimately end up with one of two problems: a retention problem, or an adherence problem, or a combination of the two. And so 6 months is perfect for someone that has retention problem. It's not for someone that hasn't disclosed at home and doesn't have to take lots of pills at home. So one of the aims of Sustain, so Tammy's also worked into Sustain and doing all our implementation side part of it. But we've got a big aim trying to unpack for whom and how it works and kind of measuring the mechanisms of how we think it works to see, is that why we think it works? And we've been working on COP-B, so does it give patients the capability, the opportunity and the motivation to engage better? And we'll measure those mechanisms. And then we'll sort of explore it with qualitative work to see how is this affecting their engagement, and then also do some work to try and understand who it worked for and look back at the differences between people that it worked for and who didn't work for in a bit of a more nuanced way than just
What's really,
age.
yeah, what's really nice about these, you know, the self-empowerment tools is that it's also able to give more engagement. It doesn't have to be in care or at the facility. The engagement can be, you know, providing lab results, providing bite-sized educational pieces, or reminding them to be adherent, you know, it's so that, yeah, I think it's an exciting area. But that was a really great presentation. Thank you.
It's fun work to be. Thanks, Jonathan. Holding my hand through it all.
Any other questions? I'm not seeing anybody online.
I have a follow-up question. This super interesting. Exciting to see the group-based trajectories. I'm sure you've seen Sia's work, but she was the same kind of PhD. And one of the things that Sia did, because he was using other data, was to look at some of the other factors, like individual level and social factors that may influence, and that would be something that would be interesting to collect. And that,
Yeah.
I guess you're alluding to that in terms of other data, but to sort of understand who people are and kind of how they fit in would really, and I know that's what you don't have in the PhD data, but I certainly think that that would be interesting in terms of a bit more than just gender and age, and that definitely, obviously, the data that we used was problematic in and of itself, and it didn't necessarily show a huge amount, but I do think that kind of understanding some of those more complex individual and social characteristics that people have would give you a little more nuance in terms of the unpacking the different categories.
The other person around here that's also within that, I think Campbell might be Ducal with DT Chef. And he also looked at a lot more granular data and didn't find anything that was predictive, which is both validating that, well, you know, maybe we don't need to collect any more data, but at the same time, a bit depressing. What is it? What do we need to do? Just tell us what to do and we'll do it. We'll help people. But
Thanks very much for being here. It's like, did you disaggregate by Sept or by sort of like rural, urban, and even, okay, because I mean, even within Cape Town there, like Keene have got a 20, I don't know how many year, decades long history of HIV treatment and activism. And it's, yeah, I mean, they probably are differences, but the pattern may be, it may be the same pattern kind of by site, and obviously some would have clubs and some wouldn't, and things along those lines. But I think if one's going to kind of be targeting subgroups, then perhaps there is a difference between rural communities and urban communities, or people living in an environment where perhaps just in the community there's less stigma involved. I mean, you can get too granular if one wants to take a public health response, but you know, when you are kind of starting to try and get a bit more specific.
so I didn't have that data.
Okay.
My data set, but with the on the move stuff, what we're going to be doing is looking at patterns of interfacility mobility and looking, you know, because now I know how to do this, we're going to look at group-based trajectory modeling of like, or just latent class of how, like the patterns that of mobility that people fall into, and then the patterns of their engagement, and see, is there a particular type of mobility that influences a particular pattern of engagement. So maybe when we do that, we could segregate by rural and urban and do it a bit. You've done something.
No, you can. What's really interesting is that Philippi is both an urban community and a rural community, because Philippi is a huge farming area. Kailicha, a little bit the same, because quite a lot of people who live in Kailicha for a certain part of the year do seasonal farm work for another part of the year. And so one person can be both rural and urban over time. And so,
If you would target facilities, that, no.
yeah, well, within a facility like Sept, like on a you've got quite a lot of people who are not there for a certain time of the year because they're seeing the work. So
And
it's
hopefully
quite,
with the PhDC, we'll pick them up if they are active in care.
The rural.
At the rural side,
yeah, our temptation is often just to label somebody or some facility as rural or urban, but actually,
People,
yeah.
but which will be interesting with the mobility stuff,
Yeah.
because we're not looking at geographic mobility, we're looking at interfacility mobility, so that will be a type of, there'll be the rural people, the urban people, people that move between urban, people that move between rural, and then the people that move between the two, and that's a good thing that.
But if we give you a 6 months probe at a time, actually we won't see that. Actually.
Yeah.
But that's maybe the system's working, yeah.
It gives it like, it overcomes the,
So this is why we would like to be able to measure mobility beyond, like, forget about the facility access, but that is a whole other kettle of fish.
It sounds so.
Yeah. We're thinking about it.
it's also why we ended up using the treatment interruptions as the measure of retention, is because it's kind of agnostic to how much drug you got. Because whether you got 1 month or 6 months, you're looking at how late you are for an expected appointment, whereas visit gaps are, 180 days between visits. That's very different for a 1 month, 2 month, 4 month, and a 6 month script or dispensing. And so it helps to have the,
The actual dispensing for 6 months.
some places.
Okay, so it's not you attend clinically for 6 months, and but you got to go pick up every month.
So naturally they're liking to, so you have 2 clinical assessments, 2 pickups, still the same, 2 different visits, everything all at once.
You
Where's the
you
kids?
get a
More of a
credit.
mess, but
Yeah.
That's really, that's.
Okay, so we had 42 clubs in Kailicha that we were doing 6 month clubs, 6 months for, and we handed them over to kids and they carried them on. So they've been going for 6, 7 years, and now City's rolling out 6 months in a number of facilities, so we'll also see how that,
And that's for stable.
stable.
But you can't
But
even
actually,
oral
that's-
contraceptive pill for 6 months.
No.
You have to collect it every month.
So we will get a sense of some other mobility for people who access other services.
I'm not, that one of my,
Yeah.
one of my, in my my PhD discussion, that whole section on how, like, we always talk about how HIV is now a chronic disease and we need to treat it like a chronic disease, but maybe we should be treating chronic diseases like HIV because it's doing so well. I looked at the sort of 1990 equivalent for diabetes, and it was something like 50% of people with diabetes are in care and 9% have an HbA1c that is controlled. HIV is doing very well, which looks like when you put money in it. Sorry.
No, I don't know if you have, well, it was a bit, because I was just curious in terms of how you thought with injectables, if they've become accessible, or because you alluded to the fact that there's an issue of ADLs and detention, and maybe injectables will take, care of the ADLs part. Or we just delay, or we just defining and disengage from care, or the
From
fact it's
90
gonna
days
flip to a longer
to
period of time.
150 days.
Exactly. But then there's also fewer options to like make a plan, and an event as well, so.
How far is your injection
Yeah,
from?
yeah, so, I don't know if you had any thoughts at all, but maybe it's a discussion. That's all.
I, on my soapbox,
Yeah.
I have a suspicion that if injectables come out for the general population, everyone's gonna get super excited, everyone's gonna want them. And then after a while, there are gonna be a lot of people that revert back to oral because the injection's painful, you have to go to the clinic more often. People want it because it's exciting and they've got treatment fatigue and they're sick and tired of taking these down pills, and this is an often difference. But then the reality of it is gonna hit them at the bottom.
I think, Catherine, I think it was her, presented some of the print injectable versus non-injectable stuff at the HIV meeting. And everybody wanted the injectable, but the people who were started and stable on oral PrEP stayed. I mean, there was massive crossover. So it's a different group, it's not a treatment group, but I think there is a lot of exceptions from injectables since the injectable contraceptives being a thing in this country. And so it's not an unusual thing for women at least. everyone thinks it's going to be a game changer.
I do think it's going to go back to being like not everything for everyone. That people need to be able to choose and be guided and say, like, what might be best for you in your life and how you change your mind. That's all right. How can we support you? And see your direction.
Yeah, but I was also going to say that with the injections, again, Catherine had another study with the Johnson's where they actually given out injections to the Johnson, and most of them have stayed on the injection. And then one just changed, I think because he moved or something, but most of them like continuously beg for the fact that he can be like, can you please continue getting on the injection? So I guess also it could be a population thing, like younger people would prefer the injection, and then the people who have been taking pills, maybe they would be more like, I prefer the leniency of having the pills with me. But also, it's just, again, so in our study, right, we've looked at focus groups for postpartum mothers, where we're asking them about the injection, and most of them, again, the biggest issue that they have about oral pill disclosure. So just there's this thing like during pregnancy, they can hide their pill because you'll just be like, oh, it's part of pregnancy. But then postpartum now, the thing of they can't hide it because, hey, what is that actually? Why are you always carrying these rattling pills? So then that's when like they start. So again, I have so many quotes. But again, if like that video asking that, is it an adherence issue or a retention issue? Because in someone with that situation, they don't mind taking their medication. It's just that they can't because of the situation that they're in, right? So they would rather have something that would be able to hide how they take their medication. But also there's just that thing of like being in denial maybe because chances are if I'm not ready during pregnancy that I'm HIV positive and then now next thing I have to like stay for the rest of my life taking these pills. It's like so many questions as to how to injection actually fit into it and how can it help improve engagement. You don't need to think about it. Once it's done, we don't just tell us anymore.
Yeah, we're going to give everyone a chance to respond to that. I think you're closing statement, and I think we'll close the people.
I think it's complex.
Yeah.
I think it comes back to give people choices, you need options, and you need to understand how these options work or what these options are good for and what they're actually doing so that you can guide people's choices to things that's going to work best for them and not everything that's going to work for everyone. And maybe we're all starting to realize that there's no silver bullet of anything. Like everyone thinks that AI is going to be the silver bullet, but AI is just a way of delivering counseling. It's not, if counseling wasn't working for you, then AI is not going to work for you either. And jumping on the next bandwagon, it's like how do we we've got everything we need to address the HIV epidemic. How do we match the right things, the right problems at the right times, and maybe focus on figuring out the targeting and the allocation of resources is a more important question than should we have injectables or not? Yes, but who and when and how? And who does it work for? And when they change their mind or their life circumstances change, how can we change with them? How can our services be person-centered so that it works for a person at all the phases of their life? As they change, they can interact in a way that works for them. And for the health, sorry, my other soapbox thing is person-centered care. The person or the people at the center of the person-centered care. It's not just the patient, the healthcare workers too. And how can we design our system so that it works for the people that use it and the people that deliver it? We do everything at the expense of the healthcare workers for the patient benefit, then well, that's maybe just because I used to be a healthcare worker.
And good advice. Okay, thank you so much. It's just gone 12. It's been a very awesome discussion. I really appreciate you and hearing all your PhD work come together. And it's been very, very good. So thank you all for being here. Thanks to those online. Continue. Everybody, thanks for the useful questions. Good idea.